Yesterday, after the whole event, we were having a small discussion. And there was this discussion which was about coronary artery disease. What else would there be? And then there was a question was, what needs to be done? So the question is, when to start and when to say that we have to keep on going. I don't have any specific disclosures. So as far as this whole cholesterol business is concerned, you have to have LDL which is shooting out and the non-HDL also being not right, which is actually triglycerides, EPOs and everything else coming in over there. Unfortunately, EPOs are not done over here on a regular basis. So risk factors for atherosclerosis would lead to cerebrovascular problems, heart diseases, peripheral vascular disease. One thing we have to remember always and teach our patients is that at the end of the day, it is a vascular system that you are looking after. Whether it is in the coronaries, whether it is in the brain, whether it is in peripheries, whether it is the aorta, it's your vascular system that needs to be checked. And complications includes all kinds of things, and no issue of any type at any age is one that you are happy to have. So risk factors for secondary hypercholesterolemia include sedentary lifestyles and a diet characterized by excess saturated trans fats and cholesterol. Hypercholesterolemia is diagnosed by a lipid profile consisting of measuring total cholesterol, LDL. This is extremely essential because many times people would come to you with only a cholesterol level and asking you whether things are on the right track or not. So definitions, epidemiology, this thing is there everywhere. And if you look at the age point of view, as time progresses, it does go down, but doesn't go down sufficiently. So every place it has to be tackled. In patients with coronary artery disease, now this is about the analysis of how you look at your patients. So let's see, you have healthy people. Some of them will have high lipid levels. But if you look at your patients who come in with ACS into your hospital, you see them coming up at a higher levels. Inshallah, from my unit, we'll be coming up with a presentation on it. We have done about 3,000 cases, and this will show you exactly the same data coming from Pakistan also. So inter and heart, etc. studies are all there. A strong correlation actually exists. Etiology, of course, is there, but one thing you have to remember is the familial hypercholesterolemia and when you should start thinking about it. So if your LDL is around 4.9, that is 190 milligrams and above in adults, and 4.1 in children, so go up and start working them for it. Now, how do you go for the children? Whenever they come in for any symptoms, for any problem, try and get this sample done. They've come in for a flu, you have taken them a blood sample, quietly do these tests also, if your insurance system and your system over there permits. Certain medical conditions, etc., of course, have it. Hypothyroidism, cholestatic liver disease, and not to forget the liver part, which is introduced by the alcohol. As far as the drugs are concerned, plenty of these drugs are available which cause these problems, but in our part of the world, these antipsychotic drugs, which are not being looked at very carefully, they also have their side effects. So the role of HDL in dyslipidemia remains debatable because there are people who have got high HDL, and it was thought that after 55 they are actually good. So, but if those who have a high HDL above 90, then what? There's always a very small proportion, but they are there also. This is the old classification that we saw when we were graduating, and this is the one which becomes more of a workable kind in which you can move further. So if a patient who is about 43 years old comes to you and is a pilot, because you know that civil aviation has their own set of rules as the age goes up. So cardiac stress test is required by his employer. He states that he has a strong family history of premature cardiac disease in his family, and 2 of his older brothers are currently being treated for high cholesterol. Systemic review is negative except for some exertional shortness of breath, and the physical examination, etc., is also slightly on the obesity side, and that's about it. So rest remains normal. So for you now, the big debate becomes what to do next. You of course do your thalliums, and you have your thalliums negative. You do then end up saying that, okay, let's also do a CT angiogram. But the question is that these things are not stated in the guidelines. So unless and until you're totally clear how you want to proceed with such patients, you have to be first get your guidelines sorted out. Other presentations may be of symptomatic cardiovascular disease patients, and they are coming in with ischemic heart disease or with strokes, etc. So they have these problems. And Currently, unfortunately, we are not looking at our enough at our eyes, etc. So arcus senalis and low density proteins, tendons, etc. need to be looked at it also. So whenever you approach your patient, remember that it has to be done with a full proper blood workup, and you have to have a proper routine history taking also with each and every systemic review. When you're doing a systemic review, please do not forget the claudication part, because that is something which is there, and many times it gets slipped by. And again, as far as the family is concerned, I would say that look into this fact, not just to the first degree families, but also to the fact that whether there was a intermarriage with a cousin, etc., at his parents' level, and could that be the reason for the excessive things going on. These are those basic images that are picked up from BMJ. And investigations are, of course, subtraction of HDL. Now you have those direct methods of calculations and the indirect methods of calculations. So extremely high lipids may give a milky blood appearance. So when you are drawing your blood, you can actually have an answer straight away over there that something is going wrong. And you have a thyroid stimulating hormone problems also coming up. So individuals with heterozygous are there with familial hypercholesterolemia 1 in 250. So remember, this is a very big number. It is there. And there are various ways of going about in calculating your risk profiling, and you can do this. And this is one of those Dutch systems in which you can have your ideas looked into. But remember that if a patient has got diabetes, then you have to look at the fact that it may be insulin resistance coming up, which may then be a reason for it. And the greater degree of insulin resistance are associated with increased VLDL productions and reduced clearance. So these are the problems which come in over there. I'm sorry I'm going very fast because they are long slides, and those of you who want them, the copies is available with the organizers. So excess body weight is there, which has to be looked at and has been discussed already. Waist circumference, etc. issue is there. Hypothyroidism is a thing that we have to look into our patients very carefully, and many times people, and if you just do a basic TSH hormonal analysis, your answers may be with you. In another study of patients referred to lipid disorders in specialty clinic, the rate of overt hypothyroidism found to be 2.8 to 4.4%. We have had this with even our hypertension clinics. We found about 3% of our patients in hypertensive clinics actually being hypothyroid. Now, the factors that can easily be managed and are associated is cigarette smoking. So things there are which you can manage, and things there are which you cannot manage. And cigarette smoking is one, of course, you can manage, and you have to go after it and explain to them. Again, the nephrotic syndrome part, you know about it. And then there are other mild alterations and high-dose thiazide and the psychotics that you have already talked about. So these are the various tests that you order in when your patient comes in for your lipid analysis, and from there you can actually come up with an idea of what to be done. As far as the genetic counseling, which is being discussed a lot, this is not something that can be offered to everyone. It is quite expensive currently. I understand, I was yesterday informed that in Pakistan this costs about 4 lakh rupees, 400,000 rupees. So it's not exactly something which can be offered to everyone. Obstructive liver disease, etc., nephrotic syndromes, chronic renal dysfunctions are all there. So remember to always risk stratify your patient. You can use various forms of risk calculators, Framingham risk, etc. But the thing over here always is that once your patients start going to the higher levels and then you start treating them, then actually you've already sort of missed the boat. So the real time actually you start to treat them is when you have got an age, when you have got these reasons why it is there, and that is why it's going on. So lifestyle modifications is something that you all have to remember that it can do, and they say that only 5 to 7%. I believe that nearly 20% correction can be done with proper lifestyle modifications if it is there. So it's good. Meta-analysis of 37 patients, etc., and etc. is going on. Do we need to get out of the hospital premise? So we have got this drug therapy of statins going on. The CTT collaboration was shown that for every 1 millimole, now this is something to be remembered, that if you can get a person's 1 millimole down, it results in a significant reduction in probability of getting into this thing. So go after this reduction as much as possible, and that is where the real benefit, of course, comes in. So statins, of course, we know what they do, and I understand there's a talk later on which will be discussing these things also further. So American College of Cardiology also gave you a set of guidelines. Treat patients As far as the elderly are concerned, yes, you have to treat them also. So it's not as if that this is a disease only for the young and they'll benefit. The elderly will also benefit out of it. Drug therapies, statins is the one, of course, which keeps on going on. Offer them all the medicines that you have. But the basic two medicines that you have, which are easily available in the country, of course, are the statins and the ezetimibe, which you can then go on. The debate about isabgol, etc., also is there. So if you're interested into those things, it may be considered. So International Atherosclerosis Society also recommended that you have to bring your LDL down as much as possible. And now there's debate going about to as the lower the better, and 50 or less is the place where you need to go. I'll just keep pushing for. As far as the side effects, etc., are concerned, myositis, rhabdomyolysis, I have not seen sufficient to say that I have got it, but they say that it's because when other drug things are also inhibiting. So you have to look at other medications which may actually be the culprit source for the whole thing going wrong. Ezetimibe is something I understand we'll be discussing. IMPROVE-IT trial was there, and PCSK9 inhibitors, etc., monoclonal antibodies. The novel drugs will be there, which will be discussed. Bile acid sequestration, etc., is also one of those things that need to be delivered on. But remember that all of these other new medicines that are coming up, the bemidoic acids, the insulinons, all of these are basically for those individuals who cannot tolerate these medicines, or you are not being able to get their targets with them. Remember to always sit down with your patients, discuss, do their discussion with them as rapidly and correctly as you do. Always have that exercise part with you, and remember that it has to be done 3 to 5 times, at least 5 times a week, and then only you can have a proper analysis. As far as follow-up monitoring is concerned, do it every 4 to 6 weeks, not on a very rapid way, because it always takes time for these things to take their time to sort of initiate, and the whole thing comes in. And this is just one thing I wanted to really say, was that one fizzy drink will immobilize your immune system by about 35%. 2 or 3 fizzy drinks in a day will wipe out a full healthy immune system from functioning that day. Sugar and refined carbs is not burned quickly, turn into saturated fats. Sugar and refined carbs, etc., are all these things. And in the end, I think we'll be having this discussion also. So if you want to be into a good place in life, nutrient-dense food should be taken, well-balanced diet should be taken, exercise, sound sleep, find first cold pressured oil for cooking, etc., and seed and nuts, and all of these things are there for you. And thank you. I'm sorry I took 1 minute extra.